Chapter 12, Assessing the Respiratory System. The functions of the respiratory system include the lungs as the chamber of gas exchange and the delivery of oxygen to all parts of the body. The circulatory system is responsible for perfusing the circulatory system, the musculoskeletal system, as well as the neurological system. And there are many considerations that need to be assessed during the respiratory system assessment. So for anatomy and physiology, please go back to your A&P books, go back and review the upper respiratory tract, which includes the nose, as well as the oropharynx, which is the back of the head, right behind the nose, right behind the throat, as well as the lower respiratory tract, and that's your trachea, your bronchi, your bronchioles, as well as your alveoli. All of those parts compose the entire pulmonary system, but it's broken down into both the upper as well as the lower respiratory tracts. The lungs help to control perfusion between oxygen and carbon dioxide and helps to control the pH. Your diaphragm is that large muscle right below your lungs, both the left and the right, that helps to support the lungs, number one, and it helps to both constrict as well as dilate the lung tissue. The diaphragm is a dome-shaped muscle, and it also separates your pulmonary assessment from your gastrointestinal assessment. The landmarks help you when referencing the pulmonary system. You need to understand the anterior thorax from the posterior thorax, and don't forget there are also lateral parts of your thoracic rib cage. So the anterior obviously is the front, the posterior is the back, and then the laterals are your sides. The lungs are cone-shaped. They are air-filled structures. They're tissue. Again, acid-base balance is maintained in these tissues, specifically at the level of the bronchioles and the alveoli. And the pleura is a serous membrane that covers the lungs. The parietal pleura in the visceral pleura. The parietal pleura is a lining that adheres to the thoracic wall, and it produces serous fluids as pleural fluid between the two pleura keeps the area lubricated so the two layers can move easily. So when a patient or a person breathes in and out, that fluid in between the parietal and the visceral pleura helps to lubricate the area and allows the lungs to expand and contract naturally without causing much pain. The visceral pleura covers the outer surface of the lungs, and it secretes a serous fluid that lubricates the pleural cavity and keeps the lungs expanded. The posterior lungs, or the posterior lobes rather, as well as the anterior lobes, help to create the lungs. You've got three lung sets on the right side, and you have two lung set lobes on the left. And this is kind of the breakdown of what they look like anteriorly as well as posteriorly. Diagnostic tests used to assess lung and lung perfusion include pulse oximetry, which is just a simple probe on the finger that assesses oxygenation in the blood. Arterial blood glasses are serum lab draws to determine the amount of oxygen versus carbon dioxide in the blood. Thoracentesis identifies whether there's an infectious process within the lung tissue, so it's simply removal of lung fluid or fluid around the lungs to determine if there's an infection. Bronchoscopy is simply identifying through a camera down the bronchial tubes to see if there is any type of obstruction, polyps, anything that might be causing difficulty with respiration. Lung biopsy is simply taking a piece of lung tissue to identify whether it's cancerous or benign. And then the tuberculin skin test is simply that test that's intradermal to determine whether, it's a simple PPD test, to determine if the patient is, it's a screening test to determine if the patient is has tuberculosis or was at risk for tuberculosis or had a history of tuberculosis. Obviously, it's a screening test, and in order to confirm, you would need the diagnostic chest x-ray. So when collecting health history, it's important to, collect the full health history. Past medical history, whether or not they've had pulmonary disease such as asthma, chronic obstructive pulmonary disease, whether they've ever had acute or chronic respiratory infections, bronchitis, emphysema, what type of medications they're currently taking, if they have a history of asthma, are they using an inhaler, how often are they using an inhaler, have they ever been hospitalized, have they ever been intubated, if they've ever had an asthma attack. You also want to identify their past surgical history, if they've ever had any chest wall surgery, if they've ever had any trauma, chest wall trauma, or any type of trauma to their lungs, to their chest wall. You want to discuss whether they smoke, drink, or do any recreational drugs. What is their psychosocial situation? Where do they work? Are they exposed to any environmental pollutants? Are they exposed to, smoking? If they don't smoke themselves, are they exposed to any secondhand smoke? And that could be secondhand smoke from cigarettes or secondhand smoke from environmental, pollutants. And then what do they do for health promotion? Are they up to date on their vaccines if that is what they, what they do? Were they ever given the pneumo vaccine, or are they interested in it? Are they of the age group that are eligible for that vaccine? You want to ask about their current history, shortness of breath, dyspnea, any difficulty with breathing, orthopnea. Do they have difficulty breathing when they're laying supine? Paroxysmal nocturnal dyspnea. Do they have trouble breathing when they're sleeping? Do they have a history of sleep apnea? Do they snore? Do they have an acute or a chronic cough? If they have a cough, is it productive or non-productive? Is it related to a previous illness that they've had? If it's productive, what does the sputum look like? Is it green? Is it yellow? Is it clear? Is it viral, bacterial, or allergic? Do they have chest pain? If it's not cardiovascular related, could it be inflammation of the lining of the pleural tissues? And then when you're preparing to do your assessment, you always want to follow the inspection, palpation, percussion, and then auscultation is done last. And you want to make sure that the patient is comfortable, seated in a seated position, and you want to do a complete 360-degree assessment of their thoracic cavity. You're not just conducting an assessment of the anterior thorax, but you're also including the posterior, okay, and the lateral, as discussed earlier. When mapping out the thoracic cage, know your reference lines, right? Your midclavicular, your midsternal. You've also got your posterior reference lines, your scapular, your vertebral, and then your axillary lines, your axillary, your mid-axillary, anterior and posterior axillary. And the start of your assessment is obviously inspection. You want to take a full 100 and, not 180, but more so 360-degree view of their entire anterior, lateral, posterior, and then lateral again. And you're looking for the size of their thoracic cage, The shape, the symmetry, is it symmetrical on both sides? Is it symmetrical anteriorly and posteriorly? Is it barrel shaped? Is it, a 1 to 2 anterior posterior diameter shaped? What color is their thoracic cage? Is it paler? Is it cyanotic? Is it pink? And then the rate of their respirations, obviously collected during your vital sign intake, but you're also assessing this when you're doing a respiratory assessment, looking at their thoracic cage. Normal findings include the anterior-posterior diameter to be 1 to 2 ratio, all right? Cone shaped, symmetrical, skin color is uniform, and your respiratory rate is between 12 and 20 breaths per minute. And this is just an example of the anterior-posterior diameter, where the left picture shows a normal rib cage, 1 to 2, and the picture on the right shows more of a barrel chested. These are more classic in patients who have kyphosis, but also who have long-standing history of pulmonary disease such as emphysema. And that is more of like a 2 to 2 ratio, or 1 to 1 ratio rather. The next step is to palpate, and you're just simply palpating for characteristics or any abnormal characteristics or tenderness related to the thoracic cage. You're using your fingertips, gently palpating, you're assessing for moisture, characteristics, any tenderness, and you're using the back of your hand, your dorsal part, to assess for temperature changes. Normal findings include that the skin is dry, that it's smooth, uniform, warm to touch, and there is no evidence of tenderness. And you'll see an abnormal finding of crepitus when they're breathing in and out, and that's simply kind of a grating sound between, the chest wall and maybe the pleural cavity, or the chest wall and the rib cage. You're palpating for symmetrical expansion, and this is important where you actually have to count down the back of the thoracic, posterior thoracic landmark. You're identifying the thoracic vertebrae, and you're counting vertebrae from vertebrae to vertebrae until you get to levels T9 and T10, which usually is a nice landmark, is right behind the elbows. So if you have their elbows straight down, you can actually find that landmark right at the level of where their elbows land. You're placing 2 thumbs right at the level of T9 and T10. You're pinching the skin in between your thumbs, and you're asking the patient to inhale and exhale. And you're not moving your hands, you're allowing the body's thoracic cage to move your hands, all right? And there should be a nice, even, symmetric movement as they're breathing in and out. Normal findings, they move apart symmetrically and back symmetrically. An abnormal finding would mean that one hand would move up while the other maybe would stay stationary or not move as much as the right hand or the left hand. And this could indicate decreased air movement in that side of the lung that's not moving. It's not allowing that chest to expand or retract. You're also palpating for tactile frummitus, and this is more vibratory sounds that are created or conducted through the bronchi. And you can ask the patient to repeat words such as 99, koi, toy, or boy in a very low-pitched sound. And you start at the clavicle and you work your way down using the palmar base of your fingers, the balls of your fingers, to feel the vibration, and there should be equal vibration on both sides as they're repeating the words. And you're repeating this both anteriorly as well as posteriorly, and then laterally. You want to identify equal findings on both sides, and abnormal findings might be related to increased density of lung tissue or fluid in the lungs if there is limited vibration felt. When you're percussing, and this takes a little bit of time and effort and work, you're percussing to assess the presence of air in each lung and density of underlying lung tissue. Normal percussion sounds are resonant sounds. Hyperresonant sounds are abnormal. You want to use indirect percussion, in which you are percussing in between the intercostal spaces or in between the ribs. And you're taking one finger and you're tapping with your other finger of the alternate hand, of your dominant hand. Again, takes a lot of practice until you get that sound right. And you're percussing the anterior chest wall, the posterior chest wall, as well as the lateral chest wall. Normal findings, again, is resonance, which is a low-pitched hollow sound, and it should be equal, symmetrical bilaterally. Any sounds that are soft, dull, or hyper-resonant could be an indication of fluid or consolidation within the lung or lung tissue. And then lastly, you want to auscultate sounds to identify airflow through all the lungs and the lobes of the lungs. You would be using your stethoscope, asking the patient to inhale and exhale, and you're auscultating in between the intercostal spaces. You're auscultating anteriorly as well as posteriorly, and you're including the lateral bases, because remember, the lungs expand, they expand outward, and so you want to make sure you're capturing both aspects of the lung tissue. Normal sounds are your bronchial, your bronchiovesicular, as well as your vesicular sounds. And then you've got your abnormal adventitious sounds, such as crackles, rails, ronchi. Your F.A. Davis has really good videos on how each of those sounds are. And I also have posted for you on your Canvas course shell abnormal sounds of lung tissue. So these are just some exemplars of, what abnormal sounds sound like. Always important to know what normal sounds like, because when you don't recognize a normal sound, then you know it's abnormal, and it could be one of these things. Advanced assessments, although not always included, could be included if you are identifying abnormal assessments with your routine inspection, percussion, palpation, and auscultation assessments. So bronchophony, egophony, and whispered picturilliquy are advanced assessments that you should learn and understand and incorporate in your practice if you identify abnormal findings with previous assessments. So your bronchophony is simply assessing airflow through the lungs. You're having the patient sit on the side of the exam table, leaning slightly forward, and you're asking them to speak 99 or koi, toy, or boy in a low-pitched sound. In that, you're auscultating the posterior lung fields, moving from the apex of the lungs down to the bases, and you're noting the intensity of the sound and distinction of the word. When the words are less distinct, or very muffled, then that is a normal finding. But if they're clear, or the sounds are more increased in intensity, that's an indication that the finding is abnormal, and there could be consolidation of lung tissue. So you want the sounds to be muffled or deep. Another one is egophony. That's very similar to bronchophony, but you can select to do egophony. And in this one, you're asking them to say E, 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 but the normal finding would be you would hear A. You're auscultating again, same thing. The posterior lung field moving from the apex to the base. And again, the normal sounds would be the letter E, but less distinct rather, and more muffled. If it's an abnormal finding, you would hear a more crisper, clearer sound, and it might sound like that would indicate increased lung density or consolidation of the lungs. And then a third test that you can do is your whispered pecoriloquy, which you're doing the same exact thing with the patient, auscultating from the apex to the bases, and you're asking them to say either 99 or 1, 2, 3, but in a whispered voice. Again, indistinct, faint, or muffled are normal sounds. When they're more clear, that's an abnormal finding. And then a final test is your peak expiratory flow rate, which is usually done in the office setting. So it's not something that you can ask them to do, simply by having them sit and then listening to the lungs. It's actually a peak flow meter in which you are assessing lung function and expiratory volume of air in the lungs. And you're usually conducting these tests on patients who already come in with a bronchial or a lung-related abnormality, chronic obstructive pulmonary disease, asthma, emphysema. In this situation, patients would be standing or sitting and upright. They would be asked to take a deep breath. They would place this peak flow meter in their mouth with their tongue under the mouthpiece, asking the patients to close their lips tight and hard around that mouthpiece and to blow as hard as they can, as fast as they can. And you're repeating that a couple of more times, and then the highest number is thus recorded as their peak expiratory flow rate. The normal findings, and it's calculated on the meter. Anything that's greater than 80 is normal. Anything that's in the 50 to 80 range is intermediate, and then anything in the red zone is 50% of normal findings.